Hello, good morning, good afternoon, and good evening to all speakers, chairs, and the wonderful audiences in different parts of the world. Welcome to the ACNS webinar. The speaker for the first session today is our guest from Indonesia, Professor Mirna Sobana. Professor Mirna is a pediatric neurosurgeon at the Dr. Hassan Sadikin Hospital, Bandung, and attending pediatric neurosurgeon at Panjajaran University Neurosurgery Training Program. She did her fellowship at the Resident on Training Chuko Hospital, Nagoya, Japan in 2007 and fellowship in Pediatric Neurosurgery Scholarship of Korean Society Pediatric Neurosurgery in 2013. She is currently the chairman of the Indonesia Pediatric Neurosurgical Committee and the chairman of Indonesia Women in Neurosurgery. We are extremely honored to have her today at our webinar, and she'll be talking on craniosynostosis, strip cranectomy or reconstruction. Our second speaker for today is our honorable guest from Japan, Professor Takayuki Hara. Professor Hara is the Director, Department of Neurosurgery, Toranomon Hospital, Tokyo, Japan. His clinical interests are focused upon the management of the cerebrovascular disorder, especially microvascular decompression, carotid endarterectomy, and management of complex aneurysm and AVMs. He's a member of the Japan Society Association, Japan Society on Surgery of Cerebral Stroke, Japan Congress of Brain Tumor Surgery, Japan Society for Skull-Based Surgery. He's a noted author with several publications in various peer-reviewed journals. We are extremely grateful to him for accepting our invitation to be speaker at our webinar, and he'll be talking about microvascular decompression for trigeminal neuralgia and hemifacial spasm, standard and modified techniques. The chair for the first session today is Professor Azmi Alias from Malaysia. Professor Alias is the head and senior consultant neurosurgeon at the Department of Neurosurgery at the Tengku Abdul Rahman Neuroscience Institute, IKTA Hospital, Kuala Lumpur, Malaysia, and also the head and senior consultant neurosurgeon at the Department of Pediatric Neurosurgery, Hospital Tengku Aziza. He's the second vice president of Asian Australasian Society of Neurological Surgeons, ACNS, and he is also the executive board member and website coordinator of the International Society of Minimally Invasive Technique in Neurosurgery, ISMIN. He's a renowned author as well as associate editor of the ACNS. We are extremely grateful for him to accepting our invitation to chair the session of Professor Mirna Sobana. And our second chair for today's session is our honorable guest from Germany, Professor Uwe Keller. Professor Keller is the professor and head of department and head of Neurosurgical Center, Spine Center at the Aspilios Klinikum Autonomo. Now, he's also a president of the Hydrocephalus Society. As a specialist neurosurgeon, Professor Keller, together with his team, an expert in the management of cerebral tumor, hydrocephalus, trigeminal neuralgia, brain injury, and cerebral hemorrhage, vascular malformation, and compression syndrome of peripheral nerves. He's also invited faculty to several national and international congresses around the world. We are extremely grateful to him for accepting our invitation to chair the second session of today's webinar. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I would like to welcome both the speaker and the chairs and wonderful audiences to this online ACNS webinar. A very warm welcome to our colleague in China, and we are extremely thankful to Professor Zubin for broadcasting this webinar on WeChat channel. Dr. Ben from Hong Kong is my co-host for today. With that introduction, I will hand this online podium to our first chair, Professor Azmi Alias. Professor Alias.
Thank you very much, Liu Bunsang, Ben, for hosting this ACNS webinar, and also to Dr. Rajakuti for your continuous effort continuously since we started the webinar during the pandemic until now. I think it's a very good platform for the young, not only young, but senior neurosurgeon to learn. It gives me a great pleasure and honor to moderate the first session on craniosynostosis. As we know, craniosynostosis is relatively rare, but for pediatric neurosurgeon, this is part of bread and butter that we treat a patient with need special treatment. And we know that craniosynostosis involves a premature closure of the sutures in young children. And if left untreated, it could result in various complications such as mental retardation, restriction to the growth of the brain, and many others, as well as abnormal head shape. And we are very fortunate today because we have one of my colleague from Indonesia, Professor Mirna Sobana, who will discuss about the role of strip craniectomy or reconstruction in managing this special case. So without further ado, I would like to invite Mirna to start the presentation.
Thank you very much, Professor Azmi. This time I would like to talk about craniosynostosis when I do stripping or when I do reconstruction. And Hasan Sadikin been my workplace since 13 years. And I also work as attendee in Pajajaran University. And craniosynostosis surgery, we have to think about do we have to do reconstruction, or do we have to do stripping suturectomy with or without endoscope? Which one should we choose? We have to do determining the diagnosis first. To determine the diagnosis, we have to take the history taking, what happened to the baby during the in the intrauterine or during the labor or neonate. Does the baby has distress inside the uterus or has asphyxia after birth or something else? And we have to do, of course, the clinical physical examination, and also, of course, neurological and developmental examination. And the most important things are radiological. And we have to learn the basic of craniosynostosis. There's a single suture or multiple suture, or non-syndromic or syndromic synostosis. Here are the picture of the non-syndromic synostosis. There are trigonocephaly, scaphocephaly, brachycephaly, plagiocephaly, and also which is anterior or posterior. And these are the subtypes of non-syndromic and syndromic cases. In the worldwide research said that sagittal synostosis is the mostly happen to the children, is 50%, and then followed by middle-pitch suture and unilateral coronal. And in non-syndromic is 90% from all the craniosynostosis case, and from the syndromic cases is only 7%, and the mostly happened to the children was the Eppert syndrome is 3%, and the other are Cetrasogen and Menke and Krausen. But in my practice, I've seen that the mostly came to my clinical practice syndromic 30% and unilateral coronal synostosis 30%, and followed by bilateral coronal and sagittal synostosis. How we determine that it is scapocephaly or brachycephaly? We have to measure the head breadth and then head length, and then times 100, and if it's below the 70%, it's called dolichocephalic or scapocephaly, and if it's over 83 cranial index, it would be brachycephaly. Here are what described by Williams et al. In 1995. He has the dolichocephalic, mesocephalic, brachycephalic, and hyperbrachycephalic. It's not much different than before still, but he has mesocephalic is range 75 until 79.9, and then hyperbrachycephalic is over 95. Okay. And we have to diagnose mostly accurate method with the CT scan. Of course, with 3D reconstruction, it should be the CT scan is thin slices. But so we, if what I do is, if the baby still neonate, I don't do the thin slices CT scan. I would like to wait. I would like to wait and diagnose it by ultrasonography, which is we can see the whether there's synostosis or not. And after the baby is grown until 3 months old, I can do the CT scan and with 3D reconstruction. So I hold the CT scan until the baby getting older enough. And we can see the growth of the skull and how the brain growth impact to the skull. Here is the follow-up from the baby with plagiocephaly. We can see that the first CT scan here, we can see that the frontal lobe is not compressing, not to compress the internal layer of internal table of the frontal bone. And months after 3 months, so the examination was 3 months old, and then this one is 6 months old, and then we can see that the brain is getting closer and compressing the internal table of the skull. So also here we can see that the sphenoid wing is already offside. It should be on the Sylvian fissure. But it's in the frontal lobe. So I have to do the bone reconstruction. And here we see that the bone from the bone reconstruction, we see that here is the closing of the right frontal sutura, and from the inside internal table, we can see that the brain compression make the chronic ICP and make the impression to the internal table. And to make the better surgical planning, we have to do the 3D reconstruction. I do the reconstruction planning by the radian dicom, so I can plan my surgery better. So what is the goal of the surgery? Is it just to correct the cranial index, or is it the cosmetic really as our major consideration, or correcting cranial index dysmorphy? But is it enough to use the correcting helmet? So is it really solving the problem? What is the real problem here? So what I think the real problem is the chronic ICP itself, in which the compression makes the brain suffering. What do we see here? We can see that the growing of the skull has stopped and make the compression to the frontal lobe. It makes the chronic compression, and we can see here its internal table of the skull bone has impressio digitate. It's the sign, a pathognomonic sign for chronic ICP. The compression for the frontal lobe could be make the child just like Professor Azmi said before, that it could be they could be get the retardation or delay speech or ADHD, or perhaps temper tantrum. So our main indication is brain compression leads to neurological deficit and or developmental delay, psychological problem that related to chronic ICP. So my goal of surgery is to avoid cerebral compression, to correct the cranial dysmorphy, to counteract the progression of the anomalies, and to achieve better neuropsychological outcome as good as possible. So what is the best technique? What is the proper technique for the best result? The surgical issues are, is it cranial fold remodeling is better than stripping suturectomy, whether it's with or without endoscope? They said we are saying that cranial fold remodeling makes the blood losses more massive, and the length of operation is much longer. Subcutaneous blood collection after the surgery will be happen, and length of stay in the hospital is much more longer. And the non-cosmetic scars, is it true? Or stripping suturectomy, how does it goes? Is it the stripping suturectomy make the small incision? Yes. Less blood loss? Yes. Shorter operation? Yes. And shorter length of stay and lower cost, of course. But is it really needed in every our cases? I don't think is it, all of that suit for every cases we get. We have to see the cases that come to us, how they are impact to the outcomes. There's a paper about the effect of the whole cranioplasty versus the strip craniectomy in the long term neuropsychological outcome in sagittal synostosis, craniosynostosis. They said that the whole fold group demonstration superior for performance relative to the strip craniectomy group in full cases, full scale intelligent quotient. So they said that it's better to do the whole fold group craniosynostosis less than 6 month age. And the academic achievement and the learning disability, they said are elective in word reading and significant enough. And in the reading comprehension after the long follow-up, there's no significant difference were noted in the percentage of subject with reading related or mathematic or learning disabilities. I jump to the conclusion, and from the paper, the type and the timing of the surgery matter for outcome. The type of the surgical intervention for isolated sagittal synostosis impact long-term neuropsychological outcome. Patient undergoing early whole fold cranioplasty attain higher intelligence quotient and achievement score relative to those undergoing strip craniectomy. Surgical management with whole fold cranioplasty performed before 6 months of age provides the most favorable long-term intellectual outcome in patients with isolated sagittal synostosis and physiomotor integration, full-scale IQ, verbal intelligence quotient, reading-related achievement. Here is the newer paper that say that in the 18 patient, which is 8 males and 10 females, with mean age at surgery is 2.6 months, the early endoscopic suturectomy successfully treats the majority of patients with bilateral coronal synostosis and afford a short procedure, a brief hospital stay, and expedited recovery. Close follow-up is needed to detect the patient will require a secondary frontoorbital advancement due to the progressive suture fusion or resynostosis of the released coronal suture. But how do I choose the type of surgery myself? The type of surgery is I could be doing my patient who came to my clinic both, not only stripping or only cranial fold remodeling or open surgery without endoscopy. It's depend on the patient. What is the advantage for the open surgery? It all allows me to tailor the osteotomy according to the type of deformity and the age of the child. Different patient, I do the different osteotomies. Endoscopic cranial release. Endoscopic cranial release, I never done it. We don't have the equipment to do that. And actually it can be done, of course, with the small incision and the shorter length of stay and the small amount of blood loss. But here is the difference between the minimally invasive using endoscope or traditional suturectomy. The timing for endoscopic, we might do it less than 3 months, but traditional order than 6 months. But for me, the stripping, I use stripping in the younger age. It's for 3 months, I use stripping. Older than 6 months, I use the open reconstruction. And the blood loss, of course, the traditional requires transfusion more than the endoscopy. Duration, it could be, if the stripping only probably 3 to 6 hours, I usually do the stripping less than 3 hours. But if it combined with the reconstruction, I could do it more than 6 hours. And hospitalization for all of my patients, usually 3 or 5 days. Okay. This is the girl, 3 months old, with unilateral right coronary synostosis. She came with me with the asymmetrical frontal bone, and she had the left eye going downward because of the frontal bone is blobbing to the front because of the right side is tightened. So the contralateral side is blown up to the front and pushing the eyes, the orbital rim downward. And this one is the CT scan. We can see that the frontal lobe is compressed. And I do the craniosynostosis, stripping craniectomy. But I didn't do only the stripping, but I also do the expanding for the frontal bone to get much more expansion for the right frontal bone. So I make this kind of wedges cutting to the right frontal bone. And this one is before and after surgery. I don't have to do reconstruction to the orbital rim. It will heal. The baby will heal herself. So we can see that her eyes became symmetrical by herself. And also the frontal bone is much better now. It's look like symmetrical. And it is symmetrical. Okay. And so why do not every case with minimally invasive? So because the age, from the age, the best result is under 4 to 5 months of age and unable to mold the remaining fold. Just like what I did the molding, a little bit molding. I'm not doing the minimally because I cannot do the more expanding to the frontal bone. So I do the it's not because I only don't have the not only because I don't have the endoscope to do that, but it's more to I can do the mold the remaining fold. And the severity, it's the worst global deformity may not be treated well with limited incision and revision. And multiple sutures, of course, the multiple sutures is really tricky if we do that only by minimally invasive. So because it's have multiple factors for of the deformation, and sometimes the minimally invasive needs second surgery by using springs or distraction. I have an older kid with the scaphocephaly. He came from another country to Indonesia, but he is Indonesian, but he wants to treat the skull problem in Indonesia. So he came to me from another island, and we see here that the kid have the brain compression and chronic ICP that eroded the skull, and the skull is thinning. So because of the temporal bone compressed by the brain, because it get tightening in the sagittal suture. I do the stripping craniectomy and also expanding, trying to expand it to the temporal by cutting the parietal bone to the side so the brain can expand very well, and to protect the sinus. I use materials, absorbable materials to cover it. So if there's any kind of bump, it not right away to the sinus. And here is the picture after the reconstruction. The antero-posterior length has already got better, and the skull itself already round, not like trigonum to the to the not again have scaphocephaly. So cranial fold remodeling, larger surgery, is it the greater change? And I can do the complex suture problem, can approach all aspect the cranial fold, appropriate for older patient, and it would be safe in the hands of the high-trained surgeon. And this one is another case of the 3-month-old come with plagiocephaly, unilateral right coronary synostosis, but the parents not decide to do surgery in 3 months, and they thinking over about the surgery until 6 months. So here's the CT scan. We can see here that the frontal bone is tightening in the right side, and also the sphenoid wing pushed forward and inside. It is placed inside the frontal lobe of the brain. So during the surgery, I have to drill it and flatten it so it's not pressing the frontal lobe. I read it in the Professor Simoji's paper on the trigonocephaly. case that they usually seen that the sphenoid wing move forward to the frontal lobe, and they drill it and remove the sphenoid wing, so the it will release the frontal lobe from the compression of the sphenoid wing. Okay, and this one is the 3D Siri bone recon when she was 3 months old. It's already bone compression and the thinning of the bone. And after 6 months later, I do the surgery when the baby was 9 months old. I do the and then because the patient get older, I cannot do again the stripping craniectomy, and then only making the line and for expanding. So I have to do the cranial fold reconstruction. So I do the cranial fold reconstruction. The incision would be full coronar, and I have to expose the all of the frontal lobe until the skull, the orbital rim, to make the good bend of the frontal base like this. So I have to remove the upper orbital rim, and I make the advancement and also the reconstruction of the orbital band from plagiocephaly like this, and is not symmetric into the symmetrical. And also I have to drill, of course, the sphenoid wing here, and usually the part which is the sphenoid wing pushed forward is in the part when the synostosis is appear. So the other part usually better, but I still drill the the sphenoid wing anyway. So here's is the, because of the patient don't have enough money to buy the much absorbable plate, so we use the nylon to fixate the bone. So we have cut the bone and placed it again and fix it with the nylon. And we here we do the how it looks after the surgery. It seems not pretty symmetric, but at least we have avoid or prevent the compression in the future for the frontal lobe. Here's is the kid after the surgery, and the hair already come back again, and it seems like she's okay. Now I have the picture. She is get better, and she already more symmetrical than this picture. And here again, a more older child. It's 13-month-old plagiocephaly with right coronary suture. It also has the brain compression and also the sphenoid wing move forward. And this one I took this picture in the previous slides. And this is during the surgery. I drill the sphenoid wing here, and I did the reconstruction for the orbital ring. We have to remove the before we have to remove all the superior orbital ring, and we fixate it with absorbable plate. And here we we fill the spaces with the osteopore, so it could help the bone to grow in the future. And at the first, the patient parents come to my clinic, said that they are afraid. This is the their second born. Their first born child was have a terrible CP, so they live in Aceh, the most western part of Indonesia. It's 1,000 miles away from here, 1,000 kilometer, more than 1,000 kilometer from Bandung. So she came to my city here in Bandung to get reconstruction because they don't want any other developmental delay, just like her sister, her older sister. So she came to us, and fortunately, after the surgery, the child is doing well, and she from the examination of the Denver 2, the child now is got the ability is more than his age. So it's really, they are really happy with that. So what about the cranial fold remodeling I did for syndromic craniosynostosis? I did for upward syndrome, for frontonasal reconstruction, and I'm joining with the plastic for the to reconstruct the fingers. And here's the CT scan. You can see that the frontal lobe is very narrow because of the compression of the frontal bone. And we can see here that there's bone thinning erosion because of the chronic ICP to the bone. And we do the frontal orbital advancement like this. And here is after surgery. And another case with Pfeiffer syndrome, we have 2 years old with Pfeiffer syndrome, came to us very late because it was early years ago. So this one is our first, actually this one is our first syndromic, multiple syndromic synostosis. So here we can see that she has ventriculomegaly, but after months we observe. Why months we observe? We didn't mean to observe the hydrocephalus, but we wait for the ICU available in my hospital is very hard to wait the ICU, and we did another CT scan, and then about months, maybe about 5 months, the ventriculomegaly not growing. So that time we didn't do any, didn't plan any VP-SAN for this patient. You can see here that the compression, the synostosis was in the coronary suture and also lambdoid suture. And there's brain compression everywhere. And we do the patient the total fold reconstruction. The position was the spine position. We use the headrest, our neck rest during we are on the flight. We use it to support the baby's neck, and then so the patient can in the nice position we can expose the whole cranium since the frontal lobe to the frontal bone until the occipital bone. And then we do the craniotomy and open the whole skull and do the reconstruction. I did this for 16 hours, and we do only from the frontal until parietal until the lambdoid suture. I don't do to the occipital lobe expansion that time, and we didn't do the advancement of the orbital advancement. Is only total fold craniosynostosis reconstruction. And we put the drain inside the ventricle here because we are afraid that there's might be ICP raising after the surgery. And this CT is after the surgery. We do the CT scan because there's in the 3rd days after surgery, the head is getting larger, and the drain here, we were close the drain after the surgery, and then the head getting bigger, and then after we open the drain, it came out CSF with high pressure. So we decide to do Vipisan after the surgery. And follow-up is mandatory. How long the follow-up will be needed, and we should do, and what we should do for follow-up. We have to do the clinical exam. We have to do the to measure the head circumference, and of course the developmental assessment at each visit is not only with the neurosurgeon but with the neuropediatrician. And the patient should have the ophthalmological exam and imaging as indicated, and neuropsychological evaluation. Like this kid, this child came to me when he was 5 months old and got CT scan. But at the 5 month when he was 5 months old, the CT scan shows no ICP, no brain compression shows, and I decide no surgery. But then the patient lost follow-up because of pandemic. And then when he is 2 years, 7 months old, he came to me with to follow up. The mother said that she wants to follow up the kids because of the boy hasn't speak yet, not a word, and he really having a severe tantrum. If he cried, it could be last until 4 hours crying until he get asleep after he cried. So I decide to do the CT scan. After, I'm sorry, the 5 months old CT scan wasn't available by the parent, and then after 2.5 years old, patient show up with the CT scan shows that the patient have ICP, and the frontal lobe compressed the compress the inner table of the frontal bone. So I decide to do the expansion to the patient. It's a simple expansion. I don't because this patient using national insurance and have no money to cover another tools. And so I use only the simple technique like this, and it seems like now the child has already has better anger tantrum. That he's no longer tantrum. If he cry, it lasts only minutes and it stops. And he already speak words like papa, mama, and only words, but it's improvement. So the parents is happy for that. So how long should we follow up? The brain is still growing until the 80 age in months. So it's growing. So from the Landrut and Gide, they said that total volume of the brain peak by 14 years in males and 12 years in females. So we have to follow up the child until they are teenagers, early teenagers. So for the conclusion, the evaluation of the abnormal head shape should be performed by a trained craniofacial or neurosurgeon to assess for signs of craniosynostosis and or increased ICP. Early intervention is a key. What we concern is about the critical function, more to cosmetic indication. Cognitive and neuropsychological are also to be concerned. Use the surgical technique depend of the patient's age and what it needed to the patient or the parents or the risk. We have to think about it. So use autolog bone as possible as it can. Thank you very much, Professor Azmi, for the time. Assalamualaikum.
Thank you very much, Mirna. I really enjoy your presentation. So Dr. Mirna started her presentation with overview about the craniosynostosis, and she emphasized the importance of a CT scan and the timing. The CT scan can be used to diagnose for preoperative planning, and the use of 3D reconstruction also is very important when you want to plan for your surgery. And Dr. Mirna also shares a lot of experience in managing a various type of craniosynostosis, from simple to complex to syndromic, and it is very interesting. I found that in your presentation, you use resorbable material. For example, when you reconstruct back, and part of it you use to cover the sutures. Do you find that is it benefit, or is it add to the in addition to the formation of new bone, or and what about the cost as well in Indonesia, for example?
Yes, Dr. And is the using of the osteopore itself, the absorbable, it's depend on the how the insurance cover them, or how much the budget of the patient. Just like I show you before, if the patient lack of budget of money, so I try to use less material to fix the bone. So about the absorbable mass, I use two types. It's absorbable mass. It's using not a mass. It's a plate, absorbable plate. I used to do to fixate the bone. Mainly, if the I use it really need it for a reconstruction of or orbital rim, because I cannot fix it well or good result with only nylon. So I have to fix it with absorbable plate. And if there's no absorbable plate, I will think of another technique. So And it might be using the titanium, but I should talk to the patient that it should be removed for after a year, and to use the another absorbable material to fill the bone gap, because sometimes there's a bone gap that too large. So I fill it with osteopore and to fill the bone gap. The osteopore is different than absorbable plate, so it's a different kind of using of it.
In our local experience, initially we use wire, but we found that wire cause a lot of problem. It cause erosion, and especially in children, the retaining of their foreign body interfere with the CT scan, and sometimes the patient can feel it. Yeah. So then the resorbable material is very expensive, and we rather use non-resorbable suture material nowadays. And the idea of craniosynostosis treatment is actually to create space. So you need to create as much as space as possible, and the correction of the fuse suture is confined to the areas affected. And sometimes I saw that in your case you have a plagiocephaly, and one of the cases that you do not do the frontal orbital correction in a small baby. That was very interesting, because in our series, most of the time they have associated with abnormal shape in the frontal lobe, and most of the time we have to correct the frontal orbital band. We have to release that, especially in plagiocephaly. But you shows that in young children you do not have to do that. Yes. So what about old children? Is it only works in a small children? I think that was about 6 months old, compared to another series that you have to do the frontal orbital band and correction.
Yes, that's the interesting part. So I was discuss this with Professor Hans Dele from Radboud in Netherlands. So he said that he do the endoscopic surgery, and I said, are you really sure that you only do the endoscopic stripping and you can change the skull base? He said yes, and he sent me a lot of papers from him, and then apparently yes, for the children, younger children, mostly in 3 years old, we only do the suturectomy, and it works. But we cannot do that after 6 months old. After 6 months old or 9 months old, I would prefer to do the open reconstruction or cranial fold reconstruction.
Okay, thank you. In Dr. Mirna's presentation, she also mentioned the importance of follow-up and multidisciplinary assessment, because when the children have craniosynostosis, the fusion of the suture is not only involved the valve, but also the skull base. They may have associated abnormality with the orbit, the immediate ear, the upper airway. So therefore, assessment is very important, especially including the genetic assessment. So this is very crucial when we're managing syndromic craniosynostosis. I think because of the time is almost finished for this section. So Liu, do we have any question from the audience?
So far, there's no question from the Q&A box.
Okay, if that's the case, I would like to conclude this session. Thank you, Dr. Mirna, and thank you for the rest who are joining us. So we'll pass over to the next moderator, Professor Uwekola.
Thank you very much, Professor Asmi. Thank you, Liu.
Yes, thank you very much for this wonderful talk. And now I try to share my screen.
At first, I will briefly introduce my hospital. My hospital is Toranomon Hospital, and this is located in the center of the Tokyo. I'm sorry for the Japanese character. Here is the Tokyo City, and the red one is, my hospital. So my hospital is very close to the Tokyo Station and Imperial Palace, and also very close to the Prime Minister's office. And here is my hospital, and my hospital is surrounded by some government offices. So first, my hospital was funded by the government, but of course, we are not treating for the government officers, but also the all kind of patients. So this is my hospital brief introduction. And in my hospital, we have three different teams, different departments in neurosurgery. I'm chairing the department of neurosurgery, doing general craniotomy neurosurgery. And we have another department named neuroendovascular surgery, chaired by Dr. Tsuruta. And also, we have another neurosurgical department named hypothalamic and pituitary surgery. This is chaired by Professor Nishioka. And we are doing surgery independently. And sometimes we have good cooperation. For example, these two teams treat complex AVM tumor like this in combination of endovascular and open neurosurgical treatment. So Professor Tsuruta had a good embolization technique. In these cases, they embolized the feeding artery from the internal carotid artery with NVCA, and after embolization, the tumor feeding was decreased markedly. And after that, I removed the tumor without not so much blood loss. And collaboration between our team and the pituitary surgery teams shows these cases as an examples. A huge pituitary adenoma could not be treated by the endoscopic transnasal surgery. So in such cases, we are doing combined surgery. I'm doing transcranial resection, and the pituitary surgery team does the endoscopic transnasal surgery simultaneously. So in this kind of huge pituitary adenoma, we remove the tumor from transcranial room. In this patient, we chose interhemispheric approach and remove the tumor and compress the tumor downward into the nasal cavity, so as to the pituitary surgery team can remove easier. This is the lamina terminalis, and I am now opening the lamina terminalis and going to the third ventriculus. And during removal, these two teams could meet from each approaches. So here is the forceps and the endoscope suction tubes from the endoscopic approach, and we can confirm the extent of resection by doing, say, simultaneous surgery. This is how we treat this kind of huge, complex figured pituitary adenoma. This is postoperative. So once again, today I will talk about microvascular decompression for hemispheral spasm and the trigeminal neuralgia. And Professor Uwe Kara did the very nice introduction. So maybe my talk, some parts of my talk may be duplicated, but I will speak from the features and causes and treatment and so on. First, I'll talk about hemifacial spasm. Hemifacial spasm has some features. It is basically unilateral. So this patient has a left side hemifacial spasm, and only left side he has a spasm. So it is different from the Mage syndrome. So hemifacial spasm is to treat the hemifacial spasm. First, we have to diagnose the correctly, and the differential diagnosis is very important. The second feature is the synchronous spasms. So hemifacial spasm usually occurs from the eyelid, but it spread into another muscle. For example, the orbicularis oris and sometimes platysmal muscles. So this is called pathological synkinesis, and it is different from peripheral spasm. And facial spasm also occurs during sleep and cannot be suppressed temporarily by oneself. It is different from tics. So thinking about these features, we have to diagnose hemifacial spasm correctly. And causes of hemifacial spasm is thought to be vascular compression. Mainly, the vascular compression was the main cause of the hemifacial spasm. But in rare cases, as Professor Ube showed, some tumor may be a cause of hemifacial spasm. And sometimes we have hemifacial spasm after Bell's palsy, facial nerve palsy. Recently, there are several other mechanisms to occur the neurovascular compression syndromes. So, for example, brain white and gray matter changes and ion and channel changes and inflammatory background. These may have a role in the development of hemifacial spasm or trigeminal neuralgia. But of course, these three factors are most important, I think. So at first, the vessels, especially the artery, compress the facial nerves, and this causes demyelination of these nerves. And this demyelination of facial nerves is not the only cause of the facial spasm, and it induces nucleus hyperexcitability, and also this may be a cause. So at last, these factors lead to the trigeminal neuralgia, hemifacial spasm, glossopharyngeal neuralgia sometimes. It is called neurovascular compression-related symptoms. So this is a schema of the hemifacial spasm. As you know, the facial nerve has a central myelin very close to the brainstem, and also the peripheral myelin. It is consists of the Schwann cells, and there is a border zone between central and the peripheral myelin. It is called Oberstein-Ledrich zone, or ZIT. This zone is known to be very fragile and also be easy to be affected by the vessel compressions like this. So vessel compression to the transitional zone, or it may be a main cause of facial spasm. And interestingly, this ORZ varies by nerves, facial nerves. In facial nerves, this transitional zone existed very close to the brainstem. Almost all cases, ORZ exists 1 millimeter from brainstem, very close to the brainstem. But in other nerves, especially the vestibular nerves, ORZ exists very close to the internal auditory canal. So it may be different from today's topic, but this may be the one reason for the vestibular schwannoma causes mainly from the internal auditory canal, not from the cysternal portion of vestibular nerve. This may be a reason, I think. And imaging, it's quite important. We are using the MRI. It is essential and mandatory to diagnose these vascular compressions. And recently, we can distinguish nerve and vessels with different color by combining the Fiesta image and MR angiography imaging into the one images. So in these images, vessels are characterized by the colored line, and nerves are not. So it is clearly distinguished vessels and nerves. I'm so sorry. So in this case, vessels compress the root exit zone of the left hemisphere left facial nerves. So MRI is necessary for the final diagnosis. And for the treatment, I'm measuring the retraction length. This is defined as a length between petrosal surface and the brain stem. This is the retraction length. And according to the literature, if the retraction length is above 40 millimeters, we have to retract the cerebellum a little bit stronger, and it may cause the hearing impairment after surgery. So retraction length can be a guide, can be a predictor for the surgical complication. How about the treatment? So medication, Botox injection, and surgery. These three are the major treatment options. And of course, the surgery is only the curative treatment. So I'll talk about the surgery from now. It is quite famous that Peter Janet started this surgery, and he reported 47 cases of MVD on 1977 in Journal of Neurosurgery. According to the literature, he did surgery in sitting position or lateral position, and linear incision, approximately 5 to 7 centimeter, 5 centimeter craniotomy, and he used the interposition method for the decompression. So the treatment result was shown here. And recently, we have some modification for Janet's procedures. In Japan, it is not easy to do the surgery in sitting position, so we prefer to do it in lateral position. And I do the MVD for hemifacial spasm with keyhole approaches, approximately 2.5 centimeter small buffer, just caudal to the inferior nuchal line. So skin incision should be centered on the inferior nuchal line, and curvilinear incision was done approximately 5 centimeters. But it is for the normal procedure, standard procedure. So the vertebral artery compression was, if the vertebral artery compression was suspected, skin incision and craniotomy should be made much larger. And recently we have some good tools to the surgical simulation. This is done by BrainLab iPlan element. And in this case, right vertebral artery compressed the root exit zone of facial nerve. So this may be the off-ending artery, and we can easily do the surgical simulation using these software. And monitoring, neurophysiological monitoring, it is quite important to keep the normal function. Auditory brainstem response, ABR, is necessary to preserve the hearing. And also, we are doing abnormal muscle response, AMR monitoring. It is a monitoring for facial spasm. So if we achieve good decompression, abnormal muscle response disappears, and during surgery, we can confirm a good decompression. So we are doing these two mulch monitoring for the hemifacial spasm. Intradural procedures, the keyword is infraflocular approaches. We should approach from inferior to the superior direction, like this. This is the left cases. So open the cistern along the lower cranial nerves is the first step to release the CSF and track down the cerebellum, and expose the intersection of ninth nerve and chord plexus. Here, ninth nerve and the chord plexus. If we open these spaces, we can easily access to the root exit zone of facial nerves. So retraction should be horizontal, not horizontal to the cochlear nerve, ACE nerve, but vertical to the ACE nerve to prevent the hearing impairment. This is the right direction of the retraction, not to horizontal to the cochlear nerve. So is the key to preserve the hearing function. And the decompression method has two ways: the transposition or interposition. So to decompress the nerve, we should mobilize the artery but we have two methods. And the first one is a transposition method. In this method, we mobilize the artery by pulling the artery with Teflon sling and fix this fibrin glue to the surrounding tissues, especially for the petrous bone. And no insertion between artery and veins. And also the other one, this was done by Peter Janetta. This was interposition. This is an interposition method. We put the prosthesis between nerves and arteries. Teflon sponge, PVA sponge are the major two prosthesis. And it is also the decompression method, and but the recurrence rate is said to be a little bit higher by this interposition method because of the fatigue of these prosthesis. So, if possible, we prefer to do transposition method in microvascular decompression surgery. I will show some illustrative cases. This patient quite old and right side hemifacial spasm. So I made approximately 5 centimeter skin incision, just medial to the ear. And the black line, the superior inferior lines, so made a skin incision like this, curvilinear with a curvilinear fashion, and split the muscles. This is a splenius capitis muscles, and split these muscles, expose the occipital bone. And sometimes we have to sacrifice the occipital artery, but in many cases we can retract this artery caudally without cutting. So here is the inferior nuchal line, and this is a superior nuchal line, and we have to centralize the inferior nuchal line in the surgical field. One bar hole, small craniectomy was done, and expose the junction and the hip of the jugular vein, sigmoid sinus. After opening the dura, first I have to cut the arachnoid very close to the lower cranial nerves by evacuating the CSF. This is the vertebral artery. Lower cranial was identified first, and from inferior to superior approach, infraflocular approach, we have sharp dissection. We should do the sharp dissection around this ninth nerve and vertebral artery, and between the ninth nerve and chord plexus, we can approach the root exit zone of the facial nerve. Here is the offending artery in this patient. The pica was the offending artery. So we could mobilize this artery from the root exit zone and put the Teflon around the artery and mobilize it to the petrous bone and fixed with fibrin glue. So we didn't see facial nerve on the cochlear nerve. Only we could see the root exit zone through the infraflocular approaches. This may be a standard procedure. This is the final inspection after mobilization of the offending artery. This was the root exit zone of the facial nerves, and good decompression was achieved by the transposition method. So monitoring was good in ABR, and abnormal muscle response was disappeared just after the decompression. Another cases. In this patient, very young woman. So I do the surgery quite similarly. But in this patient, flocculus was tightly adhered to the cochlear nerve. So I did the sharp dissection between the cochlear nerve and the flocculus to get good visualization of the root exit zone. In this patient, ICA was the offending artery, and we found small perforators from the ICA to the brain stems. So in this patient, I gave up transposition method, and in such cases, we should choose interposition method. So by putting the prosthesis between the offending artery and the leads of the facial nerve. So I've inserted two prostheses between these two structures and achieved decompression finally. This is how I do in the interposition surgery. So in this patient, ABR was also normal, and the AMR disappeared just after the decompressions. So I did not do this microvascular surgery, not so much. So last 3 cases, I experienced 50 cases. And 95 cases was cured with MVD. And some cases, the facial spasm continues as long as half years or as long as 1 year. So facial spasm is not always disappeared just after the surgery. So we should inform the patient to this surgical, to the delay of the surgical effect. So we have to wait as long as 6 months or 1 year after the surgery because it has some small spasm after surgery. Okay, skip this surgery. I will skip. And the summary for the hemifacial spasm. So treatment of hemifacial spasm starts from the diagnosis. So differential diagnosis is quite important. And the MRI, especially we are using Fiesta with MRI fusion, is quite essential. And the vascular compression at red should be confirmed with MRI. So microvascular decompression is the curative treatment, and also preoperative simulation is quite necessary. Keyhole or conventional craniotomy, which is better for the surgery. For the vertebral artery compression, I do more conventional larger craniotomies to expose much wider. And the monitoring, ABR, AMR monitoring helps us to preserve hearing and confirm the decompression. Transposition, interposition, we have two methods for decompressions. And we have to wait as long as 6 months, as I mentioned before. So we'll move to the trigeminal nerve. So these are the features of trigeminal neuralgia. It is quite electric sudden discharge with trigger, and also unilateral and no neurological deficit, as Professor Ube mentioned, and no atypical pain, no other type of continuous pain. Carbamazepine initial effect. These are the characteristics of the trigeminal neuralgia. And the causes are quite the same: vascular compression and sometimes the tumor. The arterial compression may be compressed by the SCA. Approximately 40 to 80% of the trigeminal neuralgia was the compression by the SCA, sometimes by the ICA. And interestingly, during surgery, negative exploration, so no vessel compression was found in some cases. This is also the causes of the trigeminal neuralgia. So I will skip. And different from facial spasm, or the transitional zone between central myelin to the peripheral myelin differs from the facial nerve. Trigeminal nerve has a wide variety, so very close to the brainstem, and in some patients, there are very wide range of peripheral transitional zone. So it is quite different from facial nerve. That means we should inspect not only the root entry zone, but also the whole part of the cisternal segment of trigeminal nerve in the trigeminal neuralgia surgery. So not only the reds, but also whole parts should be confirmed, should be inspected during surgery. It's quite different from facial nerve, facial spasm. MRI also helps us to distinguish confirm the diagnosis. And the treatment option in trigeminal neuralgia, we have another option, stereotactic radiosurgery gamma knife. It's also known to be effective. So if the patient is quite old and some comorbidities, the stereotactic radiosurgery may be a good surgical options, good treatment options. In this lecture, I'll talk about MVD. So epidural procedure were quite similar, but skin incision a little bit different. For the trigeminal neuralgia, the craniotomy should be centralized on the supranuclear line. So we have to expose the transverse sigmoid junctions a little bit rostral to the from the facial spasm. But the skin incision may be the same length. Monitoring only ABR. And intradural procedures, we should know the approach route to the fifth trigeminal nerves. I prefer to open the horizontal fissure first, and these petrosal vein should be completely dissected from the arachnoid, and we should use some approach route to confirm the vascular compression to the fifth nerve. So in the trigeminal neuralgia, SCA, cerebral artery, may be a main offending artery, and SCA has little perforators, so we prefer to do transposition surgery in the trigeminal neuralgia surgery, trigeminal neuralgia treatment. Some example cases, illustrative cases I will show. This patient a little bit old, but strong compression on the SCA. So in this patient, I did microvascular decompressions. Here is the supernatural line. So craniectomy should be placed a little bit rostral compared to the facial spasm. After opening the dura, and here is the transverse sinus, sigmoid sinus. This is TS junctions. In this patient, cerebellum is a little bit atrophic, so we can easily identify I can easily approach to the fifth nerve by cutting the arachnoid and around the petrous bone. So in this patient, there are a little bit large petrosal vein was observed. So first I cut almost arachnoid around the petrosal vein, and first I tried to approach from the supracerebral route, but I have some difficulties, so I changed my mind and moved to the caudal side and cut arachnoid inferior to the petrosal vein. This is 7 and 8. And also I used horizontal fissure and dissect the arachnoid between the petrosal veins. So this may be the another approach route to the fifth nerves. So sharp dissection with micro scissors is a quite good technique to make good surgical corridor. So in this patient, this intrapetrosal vein approach was the best to confirm the vascular compression. So SCA was compressed from the rostral side. So I dissected this offending artery from trigeminal nerve and mobilized it upward and fixed it with Teflon and fibrin glue. Mobilized and fixed to the tentorium with fibrin glue. So once again, I would like to say there are some approach route to the trigeminal nerve. So we should choose which the best approach route to the trigeminal nerves. And some modification. And this case patient has a small osteoma in petrous bone and a little bit younger patient. So in this patient, I first opened the horizontal fissure sharply, like the case 1. So it requires a sharp dissection, like cerebral fissure opening. And after opening, dissecting the horizontal fissure, we found the osteoma on the suprameatal crest petrosal bone. So to expose the fifth nerve with enough length, first I have to remove the osteoma with bones curette. And after removing the osteoma, we could achieve the fifth nerve. And in this patient, quite tough arachnoid was found around the fifth nerve. So cut the arachnoid sharply. And this may be I thought this may be the offending artery. And also in this patient, we have a very thick petrosal vein running close to the trigeminal nerve. And also I should have make these veins free from the trigeminal nerves. So in this patient, mobilize the SCA like the case 1, and also find out another small vessels compressing the leads of the trigeminal nerve, and also I mobilized it. And finally, I could achieve decompressions. this patient has a complete relief of the pain just after surgery. And I would like to focus on the posterior fossa narrowest, so congenital factors for the trigeminal neuralgia. According to the literatures, trigeminal nerve patient has crowdedness, narrowness of posterior fossa. So this article showed trigeminal patient has a very narrow posterior fossa compared with normal patient, and also it is also dominant in the female patient. And they said this may be a cause of trigeminal neuralgia. And we sometimes experience this phenomenon, posterior fossa narrowest, in the trigeminal neuralgia patient. This patient is a 66 years female, but she has very small posterior fossa and short segment of trigeminal artery in the cistern portion. So in this patient, I prefer to do decompression not by retrosigmoid approach, but by anterior transpetrosa approaches. So this patient was treated. Micropascal decompression was done not by retrosigmoid, but by anterior transpetrosa skull base approaches. So it is not so difficult to expose the petrous apex by epidural dissection and drilling out the petrous apex, Kawasi's triangle, rhomboid, to expose the posterior fossa dura, and open the dura of the temporal lobe, temporal base, and also the posterior fossa dura, and cut the inferior petrosa, superior petrosa sinus. After completion of these procedures, trigeminal nerve was confirmed, was identified with quite enough length, and this was the offending arteries, and we could easily immobilize it without any difficulties. So in this kind of patient with very narrow posterior fossa, anterior transpetrosa approach may be a treatment options. Okay, next one. And this is another atypical cases. This patient is very young, 19 years male, trigeminal neuralgia. So it is quite different, and this is atypical because very young. So trigeminal neuralgia patient is almost middle age, more than 40 years old. But in this patient, very old, very young guy. And according to the images, he has anomaly of the arteries, primitive trigeminal artery variant. And this primitive trigeminal artery was the offending arteries. This was a simulation with simulation software. Trigeminal nerve was compressed by these primitive trigeminal arteries. Here is the compression point. So in this patient, retrosigmoid approach was inadequate, I thought. So I also chose anterior transpetrosa approaches and open the Meckel caves can expose the trigeminal nerve with enough length by removing the petrous apex and also by opening the posterior fossa dura and cutting the tentorium, the fourth nerve, and clip the superior petrosa sinus and cut the tentorium in combination with inferior petrosa sinus. And opening the Meckel's caves. This was a trigeminal nerve, and this was a primitive trigeminal nerve, and we could easily identify the indentation of the vascular compression. So MVD could be achieved from this approach, not by the retroscapular approach, I assume. So anterior transpetrosal approach should be done for the trapezial neural surgery surgeon. In this patient, pain was relieved just after surgery without new deficit. Okay, according to the literature, some trapezial neuralgia was treated also by the anterior petrosal approaches. This was because of the anomaly of the pyramidal bone. And this was because of the dolichoectatic vertebral artery compressions. These patients are treated by anterior petrosal approaches. So we are running shortage of the time, so I will skip these 2 more cases. I'm sorry. So I'm so sorry. So in conclusion, microvascular compression for trivial neuralgia, of course, treatment starts from diagnosis, and MRI is also necessary. Different from facial spasm, vascular compression at not only the legs, but also the external segment of fifth nerve should be confirmed. And medication, rock injection, and stereotactic radiosurgery may be another options. And the preoperative simulation is necessary. Thank you so much. Thank you again for the kind assistance and kind attention. Thank you.
Well, thank you very much, Professor Takayuki Hara. This was an excellent talk, and I enjoyed it terribly much. Also, I enjoyed it that our experts are doing it quite similar. There are just tiny differences. Well, we for instance, we do it in the supine position, just rotating the head to the side. But what I want to ask you, if you do not find anything in, especially for trigeminal neuralgia, in the MRI, you still go in and have a look, or you will not do the indication for surgery?
Thank you for good questions. And we cannot confirm any vascular compression with the MRI, but the symptom was quite typical. If the symptom was quite difficult, is quite typical to the trigeminal neuralgia, I do the surgery, microvascular decompression, and in such cases, sometimes we found the tough arachnoid was fixed the fifth nerve in the external part. So after cutting the tough arachnoid, the fifth nerve became free. And in such case, in such patient, sometimes the pain was relieved just after surgery. So the symptom is typical. I think we should try MVD.
Well, from our experience, we must say that if we do not find anything in the MRI, and the MRIs are very good today, at least we have a poorer prognosis, a poorer outcome. And I think we should inform the patient about this. But if we have a real large confounding vessel, also the outcome will be better. You talked about arteries. You are now also talked about this arachnoids, which may be some hypertrophic or some scarring. How about if you find a vein? What you're going to do with veins? You just do the same, or you just coagulate them or cut them? If they are cleave or confounding vessel.
Yeah, vein may be a cause of trigeminal neuralgia, not to the facial spasm.
Yeah.
For the trigeminal neuralgia, vein may be a cause. So I hesitate to coagulate. So I cut the arachnoid along the vein and insert the prosthesis between vein and the trigeminal nerves. This is what I do for the vein compression.
Thank you very much. Well, you just stated, and this is so very interesting. If you do a microvascular decompression for trigeminal neuralgia, 90% or even more than 90% are immediately relieved from their pain. But there's a big difference with hemifacial spasm. There you have usually to wait several months, even half a year, that you can just see what is the final result. What do you think is the explanation for this difference?
I thank you, but it is not clear, so I have not correct answer. But to my impressions, hemifacial spasm have some different pathology from trigeminal neuralgia. So nuclear hyperexcitation, maybe some part for the hemifacial spasm, not only the vascular compression and demyelination. So to recover the nuclear hyperexcitation requires some months or sometimes years. So this may be a reason for the delay of the surgical effect. So it is not so much occurred in the trigeminal neuralgia. So this may be a difference. So nuclear hyperexcitability is the key for the hemifacial spasm. Is it correct for you?
Yes, thank you very much. It's very difficult because we really don't know it, but we observe it all the time. What I wanted to ask you, if you start with microvascular decompressions, from my point of view, trigeminal neuralgia is much easier and much less risky. Would you also recommend, if you start with this kind of surgery, you start, of course, with trigeminal neuralgia, not with hemifacial spasm? Do you agree with this?
Yes, exactly. Yeah, I completely agree, because we have to detect many structures in hemifacial spasm and take care of the cochlear nerves and some perforators from the ICA and hemifacial spasm. So the decompression maneuver itself is sometimes more difficult from trigeminal neuralgia. So large mobilization of the offending artery is sometimes difficult in hemifacial spasm. So technically, MVD for trigeminal neuralgia is much easier. I completely agree with you.
Thank you. Yeah, I do agree. There's one question now from the audience. In trigeminal neuralgia, where we can see clearly SCA compressing, but patient's pain is atypical with continuous pain, but not responding well to medication, would the prognosis be different from MVD?
Yeah. So the symptom is atypical. Of course, the prognosis is a little bit different from the typical hemifacial trigeminal neuralgia. In such cases, MVD has a little bit less effect for the pain relief. So, but sometimes it can relieve the pain completely. So I I have experienced some atypical pain cases, but most of the patient could be relieved by pain by MVD. So try to do MVD first and check the effect, surgical result. It's my suggestion.
Well, in our experience, we would be very reluctant to do MVD if it's really atypical trigeminal neuralgia, because we know that a lot of people have a compressing nerve even on the other side. So we never know exactly, especially in those cases, if this neurovascular conflict is the reason. But if the atypical pain has also some typical components, like some pain attacks, some shock attacks, then we just tell the patient, yes, probably this part of pain we can relieve, but the other part, it's probably may stay longer or may even not be healed with this. There's another question from Professor Ben, please.
Yes. Hello, Professor Takayuki. Nice to see you here. And thank you for your lecture. It's a really wonderful, with a very much educational value for me. I would like to ask for those recurrent trigeminal neuralgia after the MVD. So usually, how is your approach to handle this? For example, the patient is pain-free, say, for a few years, and then the pain come back. So how would you manage? What is your approach in this situation?
So the recurrence after MVD sometimes reported, but I have little experience after the recurrence of trigeminal neuralgia. Sometimes hemispheral spine has recurred, especially for the interposition method. But trigeminal neuralgia has little recurrence in my case it is. But in such cases, I think do not do the re-inspection, but to try some medication or other treatment, for example, block injection or stereotactic radial surgery. And on the other hand, gamma knife has little effect to the recurrent after MVD recurrent trigeminal neuralgia, so it may be problematic. But if we have no compression, no compression on MRI, if we do not, I think we don't do the MVD as a first treatment option. Another option should be tried first. It's my opinion.
I must say I do agree with this. You should be very conservative with re-inspection. However, we did it sometimes. We did it also sometimes successfully. However, the risk is a little bit higher, and you have some scarring from the Teflon or from whatever you have put over there. And so I agree with this, just starting again with carbamazepine, maybe also, and this would be our first approach if the medication doesn't work, that we do a thermal lesion of the gangliosacchary. You have another question?
Yes. Another question is about, I can see that you use the anterior petrosal method. So may I ask, in the procedure, do you need to put in, for example, a lumbar drain or EVD beforehand? And during after you have done the MVD, do you need to put in a fat graft to prevent the CSF leak? Yeah, thank you.
Thank you. It is quite similar in the tumor cases. So lumbar drain, I prefer to do before surgery to evacuate the CSF and to relax the temporal lobe to approach the temporal base with easier. And also fat graft should be applied to the dead spaces. It is quite similar in the tumor cases.
Thank you. Thank you so much.
Thank you very much. There's a question from Professor Asmi Ayas.
Thank you, Takayuki Hara. Excellent presentation. I enjoy very much. So you show, you achieved cure 49 of your 50 cases in MVD. So can you share with us your tips, tricks, or any secret to achieve that success? Is it a selection technique or anything?
I think the monitoring, abnormal muscle response monitoring, is a key to get a good result in hemifacial spasm. It's quite predictable for the final outcome. If the AMR disappears after the decompression during surgery, so the patient can get a good result. But in one case with little effect, I have experienced. In this case, I have little discharge, abnormal response during surgery, even though I immobilized the offending artery. But in these cases, I have not little effect. So to do the AMR monitoring and confirm the disappearance of AMR, abnormal muscle response, is a good key to get a good result in hemifacial spasm.
Excellent. Thank you.
Well, Thank you very much. Thank you, Professor Takayuki Hara. It was an excellent talk. It was really very educative. I also learned myself a lot. I enjoyed also all your comments. And I think for time issues, we have to stop now. And we thank you very much. I also want to thank everybody for joining this very nice webinar. And now I would like to transfer to Professor Boone just to say some words and to close the session.
Thank you.
Thank you.
Probably we may allow one question from Dr. Yash. Dr. Yash, you want to ask one last question? You have asked to ask question earlier. Can you unmute yourself? Okay, it's okay. It's not responding. So
Hello.
Yeah. Okay. Please
Hello.
talk. Yes. Please ask your question.
It was excellent lecture, Takayoshi sir. I wanted to ask that when in MVD, if you are doing, if there is no vascular conflict, do rhizotomy need to be done, or can we cut the fifth nerve, or we have to do just the nerve compression?
We are trying to start rhizotomy for the no compression patient. But for rhizotomy, we have some complications for the facial numbness or sensory deficit. So we should inform the patient its complication, the possibility of this complication. If the patient accepts for it, I can try to do it, but at the moment I have no experience. I'm sorry.
If I just may say some words to this, in very complicated cases where we have done MVD without success, we had done a thermal lesion, maybe even a stereotactic radiation, and patients still having typical pain. We are doing this very rarely, interestingly, and well, only for the third and for the second branch, not for the first branch, of course. And interestingly, in those patients, they do not complain or the loss of sensibility, the numbness, what we would expect it, very interestingly. And sometimes they just tell us, oh, probably you haven't cut the right nerve, but no, we have done it. It's very, very interesting. But still, I would not recommend this as a usual method. But it could be an alternative if you do not find anything and you don't have any other alternatives. You may look for this. Otherwise, it should be an exception. Thank you very much.
Thank you so much.
Thank
Professor
you.
Boone.
So we are going to close our session today. Thank you to both speakers and chairs. On behalf of the Education Committee of the ACNS and the President, Professor Kukato, I would like to thank both speakers today, Professor Takayuki Hara and Professor Mina Sobana, as well as our chairs, Professor Yui Keller and also Professor Azmi Alias for the time and support for the ACNS webinar. I would like also express my sincere gratitude to Professor Zubin for broadcasting this webinar on WeChat channel. And today we have around 600 people who join us live. And also special thanks to my co-host, Dr. Ben, for joining me today. So until we meet again online on 9th of September, this is bye-bye from all of us. Thank you very much for joining.